Thanks, Rajiv. Must be late, very late at your end.
Thank you, Abhilash. No, it's not that late. It's only 9 p.m. So it's okay.
I think we're now live on YouTube.
Good morning, good afternoon, good evening, depending on where you're from. I would like to welcome you to this webinar organized by the UN Office for Disaster Risk Reduction and the Coalition for Disaster Resilient Infrastructure. Today, we will be focusing on how we can learn from COVID-19 and build more resilient health infrastructure systems and supply chains. If I said that 2020 has been a difficult year for the entire humanity, I don't think it would be an exaggeration. It is a much repeated statement, but all of us, we can't wait for 2020 to end. There have been many, many lessons. We've seen how quickly the impacts of an event like this can ripple across the entire global system. There is no country which can claim that it is entirely unaffected. All countries are affected. All sectors are affected. It's not just the health sector, but the transport sector, power sector, manufacturing, tourism. So it has really rippled across the entire global system. So it is really, in many ways, a disaster which is instructive. This is also, in a sense, an early warning for what could happen in the future when climate impacts may reach tipping points and we can see this kind of global impact of events. So this is too precious a disaster to waste and not learn lessons from and build resilience from it. We are still in the middle of it. It's too early perhaps to draw definitive conclusions, but there are definitely some approaches that are working, some things we could have done better. And this is time to now begin to reflect and really work towards building back better. We will have huge challenges in the coming months as well. There is the whole, we've had supply chain challenges in the context of diagnostics, testing, treatment, construction of health facilities. We will also have similar challenges when we roll out the vaccination programs across the world. So to reflect on some of these issues, we've come together today. This is a curtain raiser webinar to the International Conference on Disaster Resilient Infrastructure that the CDRI and its partners, such as the UN Office for Disaster Risk Reduction, will be hosting in the middle of March. This will also build up to climate and health-related issues that will be discussed at COP26 later in 2021. So today's program is structured primarily in three parts. First, we will have three high-level distinguished speakers who will give us keynote addresses from three very different vantage points. One from a national leadership on health systems, Honorable Health Minister from India, followed by the global disaster risk management perspective, systems thinking, championed by the special representative of the Secretary General of the United Nations. And then we will have a perspective from the World Health Organization that is in the thick of it. So that's the first segment where we will talk about the big picture issues that will set the stage. The second section, we have five distinguished panelists from the private sector, from the government, people working on logistics issues, from the academia, to deliberate on some of the questions I just alluded to in my introduction of this webinar. And after that, we hope to have a fairly intense Q&A section and discussion over the remaining time. During the course of this webinar, we will also introduce some polling questions on issues that are particularly tricky, difficult, no straightforward answers, to see what is it that the international community is thinking on this. So with that, let me first introduce the opening speaker. Opening speaker is Honorable Health Minister of India, Dr. Hershwarden. Dr. Hershwarden has been leading India's fight against COVID-19 from the front. He is a medical doctor himself. He also chairs the executive board of the WHO. Dr. Hershwarden wanted to be here live with us and engage in this discussion, but currently, just as we speak, he is in the field in the largest state of India, in Uttar Pradesh, and he's on the road somewhere, so we didn't want to take a chance. And instead, he has sent us his recorded message before he got on the flight, which we'll hear now. So can we ask the organizers to play Dr. Hershwarden's keynote address, please?
Your Excellency, Honorable Health Minister from Sri Lanka, Special Representative of the United Nations, Secretary General for Disaster Risk Reduction, Ms. Mami Mizutori, distinguished panelists from WHO, National Disaster Management Offices of participating countries, distinguished panelists, ladies and gentlemen. At the very outset, I would like to applaud the United Nations Office for Disaster Risk Reduction and the Coalition for Disaster Resilient Infrastructure for organizing this webinar with a forward-looking perspective on how to make our health infrastructure and supply chains more resilient. It has been almost 1 year since the outbreak of COVID-19. While the caseload infection in many parts of the world is decreasing, many others are experiencing a second or even a third peak. Fortunately, in India, the cases are steadily coming down. We recognized the threat early and pursued a scientific evidence-based approach. Let me highlight the main elements of the multi-sectoral and proactive approach with which India handled this unprecedented humanitarian crisis. Our first step was to expand our present capacities swiftly, whether it was for testing, PPE production, or hospital beds. We looked at the problem in greater granularity and scaled up at an incredible pace. We also repurposed our capacities from multiple research disciplines across a wide range of public and private institutions. We repurposed defense research capacities for quickly erecting hospitals with enhanced capacity. From being an importer of PPEs before the pandemic, India is now a net exporter of PPEs. We scaled up our testing capacity from a few hundred tests a day to 1 million tests per day. The nimbleness that the Indian research institutions have shown needs to be not only preserved but also encouraged. The third major step was ensuring effective communication, which has been a cornerstone of our approach. We have used every possible means to mobilize everyone. The Honorable Prime Minister himself has led this effort and addressed the citizens directly. He has also emphasized the spirit of cooperative federalism, wherein the state and central governments worked hand in hand at each stage. Apart from this, we recognized early that while the health sector has to be at the forefront of combating COVID-19, it requires involvement of all of the government functions, disaster management, industry, civil aviation, shipping, pharmaceuticals, environment, and so on. We innovated early on to establish an institutional platform in the form of empowered groups to bring together these multi-sectoral functions in a cohesive manner. Last but not the least, we made innovative use of a range of digital technologies to track, monitor, and control the disease. In a country like India, with a large digital divide, we had to ensure that we use a judicious mix of different technologies so that no one is left behind. I believe that some of the good practices that have been developed in many countries of the world during the pandemic need to be institutionalized. We do not need to reinvent these in the future. At the same time, we have to think about how we could have done this better. We need a deeper conversation about what building back better in the context of public health infrastructure would mean. How do we combine modern science with traditional wisdom? How do we define health infrastructure? Is it only the big hospitals, district hospitals, and primary healthcare centers? Or is it the whole system involving other sectors, including water and sanitation, social welfare, transport, and industry? These are important issues that get thrown up and need reevaluation. Over the past decades, India and nations of the world have seen unprecedented progress in economic and human development. However, as COVID-19 has shown, all of this notable progress is at risk if we do not make our systems resilient. The key lesson from the pandemic is that the principles of resilience must be integral to our quest for economic growth as individual nations and the international community. We need to pursue disaster resilience as an essential area of common interest globally. Our lives and livelihoods may very well depend on it. In doing so, we have to make our systems resilient to not only pandemics, but all types of risks, including those emerging from the effects of climate change. We must forge a global dialogue and chart directions for a resilient future for humanity at large. This would be the most worthy tribute to our people, particularly health workers, emergency responders, frontline workers, who have put the world's safety before their own personal safety. I really look forward to several positive outcomes from today's dialogue among experts and practitioners from multiple disciplines. This will be a useful input to our own work in the health sector in India. I wish all participants a very productive session. Many thanks for giving me the opportunity to address this esteemed gathering. Thank you.
So, Honorable Minister, in his message, has posed several challenging questions. Starting from a very fundamental question about how do you, in the post-COVID-19 era, when we talk about building back better, how do you define what is health infrastructure? Where do you put boundaries around it? And how do we go about building it? He is also talking about not just looking at risks emanating from pandemics and biohazards, but also other risks and the role of health infrastructure in it. With that, I would now like to introduce the Special Representative of Secretary General, Madam Mami Mizutori. Madam Mami Mizutori, in the area of disaster and climate resilience, really needs no introduction. She's a global leader in this space. She's a champion of our cause. We always look forward to her support, encouragement, and guidance. She has been one of the key mentors of the initiative on the Coalition for Disaster Resilient Infrastructure as well. If I could, I would like to highlight that the whole notion of systemic resilience, before it became topical in the context of COVID-19, Madam Mami Mizutori was advocating it at least 2 years ago. the whole thing that we have to look at disaster risk reduction in a broader framework and look at health-related disasters as well. The discussion precedes the pandemic as well. And Madam Mami Mizutori has been at the forefront of these discussions, and I'm very much looking forward to what she has to say to us during this webinar. Madam Mami Mizutori, the floor is yours.
Thank you very much, Kamal, for your very kind introduction. Honorable Minister of Health of India, distinguished speakers and panelists, and to everyone listening online, I would like to extend a very warm welcome from Geneva. Now, this is a very timely discussion as we are beginning to see some light at the end of the tunnel of this long, hard year that Kamal, you said that we all want to forget. A year of death and suffering for billions of people across the globe. And yes, the vaccines are welcome, but we know from the experience of the last 12 months that we can't simply relapse into a pre-crisis state, even though we have found an antidote to this coronavirus. Instead, we need to confront the mistakes, let's be honest, made, and we must apply the lessons learned to reduce impact of future disaster events, because there will be future disaster events. It was actually largely thanks to the experience of UN member states in dealing with previous disease outbreaks that health figures so prominently in the Sendai Framework for Disaster Risk Reduction, the global plan for reducing disaster losses, which was adopted 5 years ago. And in fact, one of the Sendai Framework's global targets is focused very much on the subject under review here today. It is the target which calls for a substantial reduction in disaster damage to critical infrastructure and disruption of basic services, including health facilities and services. In the first instance, this applies to where health facilities are themselves in danger of destruction by an earthquake, a flood, or a storm. And as is often said by WHO, the most expensive hospital or clinic is the one that collapsed first in a disaster because the physical structure was not built to a high enough standard, or to begin with, the location was badly chosen. And there are many sad examples of this. In 2004, the Indian Ocean tsunami destroyed 60% of the health facilities in Banda Aceh, Indonesia. And flood damage in Malawi in 2015 saw medical records destroyed and the loss of drugs for people living with HIV, AIDS, and TB. So it was extremely insightful, the initiative by the Prime Minister of India to call for the creation and launch this Coalition for Disaster Resilient Infrastructure, CDRI, which is attracting very rapidly other governments, many other governments, to join, because they recognize that much of the economic loss attributed to disasters comes from the damage to critical infrastructure. And in fact, it is a double blow, because these facilities are not there when you need them most, i.e. in the disaster response phase. Beyond the challenge of maintaining resilient physical infrastructure, COVID-19 and other disease outbreaks in recent years have revealed further gaps in our health systems and supply chains of medication and health-related materials that undermine our capacity to save lives and reduce ill health. Supply chain disruptions have also affected the availability of non-COVID-19 related medication and materials, even in developed countries, because we have heard the EU reporting shortages in commonly used drugs such as antibiotics. And in the least developed countries, the situation is beyond our imagination. It is very dire, as the spread of COVID-19 is predicted to highly impact the provision of very basic medical services, maternal care, immunization, and nutrition. Obviously, there is a serious amount of work ahead to identify all the issues we have, which have led to the overburdening of the health system, infrastructure, and supply chain. And there are deep-rooted vulnerabilities in industry practices, healthcare policies, infrastructure, logistics, risk assessment, and supply chain management, which can undermine effective prevention and response. We have seen how previous disasters have affected the global food supply and disrupted the automobile industry because just-in-time production, a modality to save costs as much as possible, led to shortage of vital parts at times of emergency. It should not have been a great surprise then that this pandemic, which had long been foretold by WHO and others, has resulted in disruptions in the supply of materials and medication globally. A failure to meet demand for PPE resulted in competition for resources and ballooning costs. It is expected that many governments will be seeking ways to diversify their supplier base, preferably bringing it closer to home. And extreme weather and the emergence of new pathogens will add to the burden of healthcare in the future. It must also be recognized that little international spending on climate adaptation is actually going toward public health programs. Now, more than ever, the links between climate change, disasters, and public health needs to be understood so that investment in public health infrastructure and services are all risk-informed and resilient to, importantly, as the health minister mentioned, to multiple hazards. Our own review, UNDRR's own review this year of existing national strategies for disaster risk reduction, it has highlighted the lack of focus on biological hazards in many of them, and this is now being addressed. Overall, the COVID-19 crisis is telling us that we must strengthen disaster risk governance. Good risk governance is the best thing we can do. Bad risk governance is the biggest risk amplifier. And we must integrate disaster risk management into healthcare provisions at all levels. We need to increase investment in prevention. We need to ensure many other things. The list is long. For example, investment decisions need to be risk-informed. Reporting and accounting mechanisms need to be improved. National regulations that govern design and maintenance of health infrastructure need to be strengthened. Private sector needs to be engaged in the development and implementation of disaster risk reduction and resilience strategies. Knowledge and capacity of frontline workers and health responders on prevention needs to be built. And in closing, I would like to congratulate the CDRI Secretariat and my colleagues at UNDRR for organizing this webinar because I am confident that the insights and recommendations which will come out today will be an essential part to tackle all these issues and also be an essential part of the recovery and preparation for the next pandemic whenever it may happen. Thank you very much for your attention.
Thank you very much, SRSG. You painted a very vivid picture when you talked about Indonesia and Malawi and how 60% of the health infrastructure there was wiped out, and you don't have that critical facility just when you need it, and thus it's the most expensive health facility that one loses. The challenge that you posed about how do you balance efficiency and resilience, efficient supply chain with just-in-time supply of automobile parts, whereas a resilient supply chain. So how do we get around that? You pointed out how in the adaptation space, climate adaptation space, how little is being done to make the health systems resilient. And above all, the whole notion that risk governance is the essential. That is something which ties everything together. And good risk governance is the cornerstone of our resilience building efforts. So thank you very much. And that really sets the stage for the discussion for the rest of this event. With that, now let me turn to a colleague from WHO, an organization that has been in the thick of things for the last 1 year, really working very hard to support countries, to support issues that connect multiple countries in the context of COVID-19, providing technical guidance on a whole host of issues regarding the management of COVID-19. So from WHO, we have Dr. Michel Yao. He's the Director of Department of Strategic Health Operations in the Emergency Response Division of WHO. Dr. Yao has more than 2 decades of experience working on emergency health issues. He has been in the thick of several crises, health-related crises in the past as well in Africa and other parts of the world. He has the experience not just of working on COVID-19, but also the Ebola crisis a few years ago in Africa, in Western Africa. Dr. Yao, the floor is yours.
Thank you very much, Mr. Chair, and greetings from WHO DG, Dr. Tedros, as well as the Deputy Director General, Mrs. Dr. Susanna. Honorable Minister, Special Representative for the UN Secretary General, and distinguished panelists and participants. My interventions will be around 4 points. The first one is building back better. The second one is resilient health system. The fourth one is the build resilience infrastructure. And the last one, a call for investment. So we must start building back better for COVID as the ongoing preparedness and response action at national, regional, and global level. WHO is committed to leading and working with all countries and stakeholders on health first focus of the UN framework for the immediate socio-economic response to COVID in collaboration with other pillars for recovery. Many countries have already been facing concurrent emergencies over the last few months, especially those with fragile, conflict, and vulnerable settings. COVID-19 has reinforced the need to bridge the investment gap in the capacity of healthcare facilities to deal with epidemic and other emergencies from local to global level. Health infrastructure and supply chain need special attention in recovering from COVID. Many of the services have been totally fragilized by COVID due to interruption of supply chain. And this could have an impact in the coming years if we take the example of vaccination, for example, in many countries. So primary healthcare is a whole society approach to health aimed at ensuring the highest possible level of health and well-being and promoting equitable distribution by focusing on people's needs as early as possible and as close as possible to their everyday environment. So bringing health close to communities. People's health and health services depend on health infrastructure, such as care facilities at all levels, has been seen through the length of healthcare provided in primary healthcare facilities and hospitals during COVID. About resilient health system, we must build a resilient health system to advance universal health coverage and health security to protect health infrastructure and supply chain. And this by leveraging on the current response to strengthen pandemic preparedness and health system. Investing in institutionalized mechanism for risk-informed world society engagement. Promoting enabling environment for research, innovation, and learning. And the actual COVID teaches us that pulling all our resources together in terms of research can help us to address critical gap. We have example of vaccine production that has been sped up based on these big alliances that were set with WHO and also different partners around the world. Increasing domestic and global investment in health system and emergency, as well as disaster risk management to strengthen essential public health functions. It's important that the countries got informed policies against different risk in terms of surveillance, as well as early detection and response. We need also to ensure that we address inequities that are linked to the COVID response, mainly affecting vulnerable population. About building resilience, health infrastructure and supply, WHO Safe Hospital Initiative built on more than 20 years of technical assistance to member states for safe and resilient health facilities, including supply chain management. It has been a forefront of joint UN and WHO work on disaster risk reduction. This initiative is prominent. It is a prominent feature of the WHO framework on health emergency and disaster risk management, and the Sendai Framework for disaster risk reduction, which includes a target on safe hospital. WHO is supporting countries to enhance safe hospital capacities. WHO has also has been providing assistance to countries to assess the safety of health facilities. More than 5,000 care facilities using WHO hospital safety index for all types of emergencies, including for disease outbreak. And for COVID, WHO has published the Rapid Hospital Readiness Checklist for COVID used by countries to determine the readiness and action to improve the level of performance. Strong and safer health infrastructure and supply chain management has been critical for the continuation of essential health services for vaccine deployment, for example. Risk-informed whole of society action are critical to make the health infrastructure and supply chain resilient to all types of emergencies and disasters. And lastly, we need to really appeal for more investment as well as political commitment. Enhanced investment for health emergency preparedness, response, and recovery will be needed to support countries mitigate the impact of health emergencies. Investing in health system, including being better prepared for and mitigating risk of future threats. Taking mobility into account in terms of the impact of health emergencies. The risk of environmental and climate change is also to be taken into account. And One Health approach, considering the interface between human and animals generated by intensive animal production, environmental intrusion, and increased human consumption of wildlife is also critical. And finally, we must be solidarity. We must build solidarity among countries, donors, and partners to ensure that the road to recovery is equitable. We must be mutually trust, and we must be mutually trust and accountable, such as through the plan Universal Health Coverage Preparedness Review, which will bring nations together as neighbors to support a whole of government approach to strengthening national capacity for preparedness. No one is safe until everyone is safe, and exclusion is more costly in the long run. Thank you very much for your kind attention.
Thank you very much, Dr. Yao, and those were really remarkable, quotable remarks towards the end that no one is safe till everyone is safe. And throughout your remarks, you repeatedly highlighted the issue of being closer to community, ensuring equitable access, solidarity world around. We have to work for everyone's safety. take a whole of society approach. And your reminder of the work that was done earlier on Safe Hospitals initiative is also very important. There's a body of work done over the last 2 decades on safe hospitals. A number of countries, including in India, we have national guidelines on safe hospitals. It would be good to go back to those and see how those guidelines need to be revisited in the context of the lessons we've learned from COVID-19. Now, before we move on to so thank you very much, Dr. Yao. Before we move on to the next segment of panel discussion, may I now invite the organizers to pose the first poll question for the audience. So the question is, what is the biggest challenge for safe and resilient healthcare infrastructure? Safety of healthcare workers, overcapacity of hospitals, meaning excess capacity of hospitals and supply chains, good vaccine distribution, or better surveillance tools. Which is, of course, all of these are important, but in the current context, which is the biggest challenge? Can we see the results, or the poll is in progress? Sorry. So having excess capacity in hospitals and resilience in supply chains, excess capacity is the biggest challenge, making that happen, followed by safety of healthcare workers, and followed by surveillance tools. Somewhat counterintuitive. The challenge of vaccine distribution is rated as not among the top 3. So that is a very interesting perspective from the participants of this webinar. But certainly the top one, how do we build excess capacity so that we are able to deal with large-scale health emergencies? How do we make sure that our supply chains have enough redundancies to survive such shocks? So with that, now let's turn to the panel. We have 5 very distinguished speakers. We were scheduled to have Honorable Minister of Health from Sri Lanka, but unfortunately she is busy in another meeting and is not able to join us. So we have Dr. Hemant Herath. He is the National Coordinator for Health Sector Disaster Risk Management in Sri Lanka. Can I invite him to present his opening statement based on Sri Lanka's perspective? Sri Lanka is a country with robust health systems. It has done a creditable job of rising up to the challenge of managing COVID-19. What are some of your lessons, and what is it? Where do we go from here, learning from the lessons of COVID-19? Dr. Herath, please.
Thank you, distinguished panelists, ladies and gentlemen. Good day to you all. On behalf of the Honorable Minister of Health, Mrs. Pavithra Wanniarachchi, I would like to extend apologies for not being here today, and I will be reading the message prepared by her to be delivered into this distinguished audience. I quote, "It is a great pleasure to address this distinguished gathering to share some thoughts on the path that Sri Lanka has traveled in managing the COVID-19 outbreak. At the outset, I would like to mention that Sri Lanka is a country with a resilient health system which has delivered excellent health indicators in a cost-effective manner. The management of COVID-19 pandemic was in essence a continuation of the same health system to address the evolving needs. Under the leadership of His Excellency the President Gotabaya Rajapaksa, Sri Lanka has mounted a whole of government response in tackling the COVID-19 in Sri Lanka. The National Action Committee was established in 26th of January 2020, even before the first case was reported in the country. This committee was chaired by myself as the Minister of Health and comprised of health authorities, triforces, police, senior administrators, non-health stakeholders such as civil aviation authorities, immigration, tourism industry, and disaster management center of Sri Lanka. Though not expected the situation of this magnitude, the health sector of the country was ready to face any outbreak of disease of this nature through a comprehensive disaster preparedness program covering possible biological threats. We were properly equipped with the trained staff and well-equipped facilities, including sufficient personal protective equipment, at least to face the initial threat. In order to augment the capacity of the Ministry of Health in responding to the pandemic, the National Operations Center headed by the Commander of Sri Lanka Army and the Chief of Defence Staff was established, which was instrumental to optimize intersectoral coordination. A national strategic plan was prepared and executed with frequent reviews conducted on a daily basis. In order to obtain the technical guidance from the professionals, several technical working groups were established. In addition, National Health Emergency Operation Center was activated by the Ministry of Health to mainstream functions across the different stakeholders at all levels. Points of entry surveillance was strengthened with thermal scanners coupled with stringent mechanism for quarantine of returnees from high-risk countries. Returnees from high-risk countries were contained at quarantine centers. Subsequently, based on the risk levels, points of entries were closed. Immediate closure of schools, preschools, universities, and other vocational training institutes, both public and private, was done soon after the first Sri Lankan was diagnosed as COVID-19 positive. Island-wide curfew was imposed to promote social distancing. Under the leadership of the epidemiology unit of the Ministry of Health, contact tracing of active cases was done through a regional epidemiologist, medical officers of health, and public health inspectors supported by armed forces and the police. All above activities at field level were closely supervised by the relevant district and provincial directors of health services. Further, daily situation report on the COVID-19 situation of the country has been shared with all stakeholders. PCR testing for COVID-19 made available through the externally accredited national laboratory network with several laboratories in major hospitals. These tests are offered to all suspected patients, first line and second line contacts of confirmed cases, people who are at the quarantine centers, and epidemiologically linked community hotspots. In order to augment the patient management capacity, several hospitals were identified to provide the isolation facilities, starting from one specialized hospital for management of COVID-19 patients. To date, we have been able to increase the number of COVID-19 hospitals and intermediate care centers up to 67, covering 10,000 total bed strength. Intensive care units are also identified for the management of severe cases. Clinical management guidelines and other related guidelines developed and shared with clinicians throughout the country. Triage system was implemented at outpatient departments for early identifications of patients with COVID-19 symptoms, and services were provided through a dedicated team of health staff. Hospital infection control practices were strengthened through capacity building of health staff and stockpiling of personal protective equipment. During the curfew time, essential medicines for those who are taking treatment for chronic diseases were delivered to the doorstep through postal services. In addition, a separate gigantic mission was launched by the government to support the most vulnerable groups affected by the mobility restrictions. Risk communication activities were coordinated by the Health Promotion Bureau of the Ministry of Health. Planned and frequent messages were communicated through audiovisual, print, and social media. In addition, rumors were monitored and managed effectively, minimizing the panic among the public. Logistics, procurement, and supply chain management was sustained through a special procurement committee at the Ministry of Health, ensuring fast-track procurement despite the global scarcity of PPE and laboratory supplies. Essential health services like health, banking, electricity, water supply, and garbage disposal continued. Operational guidelines on preparedness and response for COVID-19 outbreak for work settings were developed and disseminated with the government and the private sector organization. Multidisciplinary innovation and research activities were promoted and carried out even during this crisis. As a vibrant democracy, Sri Lanka was able to successfully conduct the parliamentary elections under such health guidelines. In addition, the government was able to successfully complete the Year 5 scholarship examination, which include the children all over the island, and advanced level examination under the health guidance with no transmission of disease in relation to them. At present, Sri Lanka has faced one of the largest clusters that it has ever witnessed so far. We have in full capacity in curtailing the above outbreak, and we are confident that we would be able to control this large cluster also successfully. Thank you. I unquote. Thank you very much for listening the message of Honorable Minister. Thank you.
Thank you, Dr. Herath, for reading out that message from the Honorable Minister. A really impressive, wide-ranging, comprehensive, and timely measures taken by the government of Sri Lanka in managing this, this pandemic. I will come back to you when we get into the discussion. There was a point made on the poll question that the challenge is not having overcapacity. Of course, I think what is meant there is the challenge of having overcapacity, the need to have excess capacity redundancy to meet the needs when they happen. So actually the challenge is, how do you go from shortage of capacity to having excess capacity, having that buffer to manage the crises when that occur, that require very quick upscaling. With that, now let me turn over to the next speaker. We go from the public sector to the private sector. I would like to invite Dr. Raza Siddiqui. He is the Chief Executive Officer of Arabian Healthcare Group based in United Arab Emirates. So health sector, private sector has been obviously a very key player. There isn't a single country where the public health systems have been stretched, and successful management of this pandemic has required very close partnership between the private sector and the public sector. The public sector facilities have really come up. They have repurposed their facilities to manage COVID-19. There are many good practices. There are many lessons learned. I would invite now Dr. Raza to present his perspective from how it has worked so far, what we can learn, and how do we build back better from here. Dr. Raza Siddiqui.
Thank you very much, Kamal, for the nice introduction. And thank you very much, Ms. Mami, and thank you very much for the representative of healthcare of Sri Lanka. I will be representing the perspective from a private healthcare provider angle from the beautiful country of United Arab Emirates. I have been into healthcare for more than 3 decades, India and UAE, and it is my privilege to witness a young country coming together, a unique combination of public and private partnership to manage this crisis, which most of us in the healthcare industry have never seen in our lives. In this situation, I will talk in 3 areas. I will talk about the government initiative, and I will talk about how private sector in collaboration with government has managed to manage this situation beautifully. And third is the business continuity, which is a very, very important angle for all the private stakeholders and private business partners. When the situation of COVID came, both private and public sector got together in healthcare, and UAE managed it so beautifully and seamlessly that the country is almost fully controlled now. The public and private sector got together, and government played a key role in allowing. First thing was, this is a young country, to allow COVID testing facilities to come up within a short period of time. So private sector and public sector both were allowed to do extensive COVID testing. Government collaborated with private healthcare sector in mass screening. They identified the probable pockets, the hot pockets, hot zones, went very, very aggressively and screened masses free of cost. Then government at the same time created international quality quarantine centers. Almost all the 5-star hotels rooms were converted because tourism was also the first industry to be hit and the travel was curtailed. So most of the hotels capacity was available. The people identified were identified, diagnosed, isolated, and treatment was planned. This was done very well, and the hospitals suddenly became full. All the private hospitals and all the public hospitals, because it was a crisis time and the treatment modalities were not very clear because we were dealing with this virus for the first time and there were no clear-cut guidelines and medical pathways available. So, but it happened very well. What happened? The private healthcare sector suffered a lot because in a young country like this, the major business was coming from outpatient services to a tune of 70%. Suddenly, the patients were scared, and also it was very, very important for the hospitals to also restrict the normal patients. So business suffered, and inpatient services were also suffering because the elective procedures were also stopped by the government for the time being so that the full attention could be given to the people who require COVID care. This continued for 2-3 months, but now the situation is that in a young country like this, where we have a population of close to 9 million, we have together government and private sector have already done more than 18 million COVID testing now. The testing is available almost free of cost to everybody, and it is being done regularly, and the situation is totally under control. I will come from the point of view of private healthcare providers. As has been said by the previous speakers, during such disasters, the infrastructure is also hit. Here, fortunately, the infrastructure was not hit, but the morale of the people was very, very important. And one of the main questions here, which was asked previously, was also on the same lines. So we had a serious situation that the staff was a big situation because their exposure was very, very strong, and to deal with the patients, they were really scared. So what we did was, I will give you an example of a RAC hospital, which I represent. We set up our own COVID testing facility, and it was done within a period of 2 weeks. The government supported us, and within 2 weeks, they gave us a permission to start COVID testing. For us, everything was available. Supplies could be made available. Everything, material could be made available. But the most important thing is if the staff members, the healthcare providers, the frontline workers, if start suffering from the disease, who is going to take care of the patients. So we did some of the measures which I would like to share with other panelists, and it can be a good take-home message and we can learn from each other. We started testing every employee to give them confidence every 15 days. So there were two things. The patients coming to the hospital were confident that they are going to a facility where every employee is being screened regularly and their exposure is minimized. Second thing is, staff was feeling secure that in case there is a problem, it will be identified and treated. At the same time, we set up our own private quarantine centers for our staff. If they start suffering, we have a good place for them to recover. So these were some of the measures. Sanitization program was extensive in countrywide, hospital-wise. Every place was being disinfected every 2 hours. Now, the end result was that private sector started suffering in terms of business because they were not able to run the hospital for normal people, and patients had great difficulty. Patients having chronic problems, they were staying at home, and because of the fear of COVID, they were not coming to hospital. Here, the government plays a very, very important role. Within 3 months' time, they made almost all the private sector hospitals COVID-free. What they did was they came up within 2 months' time with almost 20,000 beds, and they did it as field hospitals. And private sector helped government in mobilizing the staff and managing them there. So end result was the business continuity of private sector was also taken care by the government, and government worked with private sector for COVID testing. But as far as the management of patients is concerned, it is now taken care by government to a large scale. So now we have guidelines, we have better protocols, large number of patients can be managed at home. Patients who require hospitalized care, they have government facilities and they have government field hospitals where they are being managed. So we are talking about a role model public-private sector partnership here, where there is a win-win situation, and we have a country where mortality rate is almost less than 0.3%. So this is a very good example of private-public partnership in building resilience in healthcare infrastructure and facilities. Over to you, Kamal.
Dr. Reza, that was really fantastic. I think the way you described the UAE experience of the public and private sector working together, where although private sector bore a lot of losses in the beginning, as the private sector helped the public sector ramp up its capacity, the caseload in the hospitals in the private sector went down so that you could take care of your outpatients, people wanting elective surgeries, elective procedures, etc. So that is really a very good this thing where government is not just requisitioning the capacities of private sector, but also using private sector expertise to ramp up its own capacity to rise to the challenge. And your point on not just looking at hard infrastructure, but also building the confidence of the health workers. You know, I mean, the hardware doesn't work without the software. You know, they are the software of it. They are the human face of it. And you know, the specific measures you talked about, you know, providing them testing every 15 days to have confidence in them as well as the patients, really good. We will come back to that. Now let's move to Africa. We have the head of the National Disaster Management Authority of Liberia, Mr. Henry Williams, and we would like to hear from him. Liberia, particularly that part of Africa, has also had the experience of managing the Ebola pandemic, Ebola crisis, Ebola infections several years ago. So what were the lessons from Ebola that came in handy in managing COVID-19? What are some of the new lessons we learned? So we would like to hear very much the Liberian perspective on it. Mr. Williams, the floor is yours.
Thank you, Kamal. And I want to say thanks to the organizers, the UNDRR and the CDRI. And I want to say good morning to all of the other participants. And we are gratified to be on this panel. We want to talk a little about the Ebola experience as it relates to the coronavirus. The first thing is that all of the health officials who fought Ebola during this world deadliest outbreak of the disease in Liberia resurrected the tools they used during the crisis to save off the coronavirus. When COVID-19 first appeared in the region in late of March, health officials employed the strategies used during the 2014 to 2016 Ebola outbreak, including isolating people who tested positive for the virus and quarantining those who may have been in contact with it. These actions probably slowed the spread of the virus. We had the experience of Ebola, so the political will was there from the start. This was even shown by the production by government of document which is termed the Government of Liberia Economic Stabilization and Recovery Plan. This plan was produced to be used from 2015 to 2017. So as of March 2016, Liberia reported 10,605 cases of Ebola with 4,809 fatalities. That's a 45% fatalities. During the outbreak, of course, household income plummeted, schools and hospitals were forced to shut down their doors, etc. Now for the COVID, presently, our confirmed cases are about 1,774 with 83 fatalities. At the onset, what we did at the onset, coordination mechanism were put in place. And this coordination mechanism at the onset was put in place by the National Disaster Management Agency. We triggered our coordination and platform, DRR platform, with all related or concerned government ministries, agencies, the private sector, the communities involved. And what we did, we had clusters. For instance, we had coordination, security, and communication cluster, and we had cluster leads, and we had cluster supporting institutions. Like for instance, for the coordinating the Disaster Management Agency and the Ministry of Foreign Finance and Development Planning were the lead. So we had clusters supporting. And we also have, for the cluster, we have, let's say, WASH, health, psychosocial. We had food nutrition clusters, shelter and non-food item cluster, logistics and supply cluster, and other partners like religious groups, etc. The NDMA holds, we are holding weekly coordination meetings to discuss the preventive mitigation and containment issues as relates the coronavirus. Well, as the virus spread, the Ministry of Health and the National Public Health Institute, NPHIL, took over the situation, and as the situation was termed a health emergency. So the incident management system was put in place, and it was headed by NPHIL, the Ministry of Health, and it was co-chaired by the NDMA. So you could see that health was not only going its own way, but health was going with the disaster management agency. So disaster risk reduction activities were brought to play, because this was composed of the same players in the NDMA platform, including NGOs, religious groups, the One UN system, etc. But instead of using clusters, they use, or we are using now for the health system, we are using pillars. And we have, instead of clusters, we use pillars. And in these pillars, we have, for instance, contact tracing, psychosocial, logistics, WASH, risk communication, EPR surveillance, etc. But another key thing that we relied on was the EOC, the Emergency Operating Center, which played a very vital, or is playing a very vital role in giving early warning, risk information, etc. So as the coronavirus spread in January, this is now where the political will is coming from. The president, George Weah, formed a coronavirus task force called the Presidential Coronavirus Task Force that included many of the same old doctors, public health experts who led the Ebola response. The group resurrected the main pillars of outbreak response and started acquiring coronavirus test kits from the World Health Organization, WHO, coordinating team of people to even do contact tracing, communicating health messages to the public. And the task force is meeting regularly to adapt responses to the latest situation, just as it was done during the Ebola outbreak. In addition, the president also constituted another body to coordinate the entire COVID-19 response called a Special Presidential Coordinating Committee on COVID-19, SPACOV. The strong political will was shown. And we also work with the US Center for Disease Control and Prevention, and they also help in teaching health workers the soft infrastructure, teaching health workers during the Ebola outbreak. And they are also here with the coronavirus, helping with the coronavirus issue. So they help us to really re-emphasize what contact tracing is, because that's one of our strengths, do the contact tracing, and in order for us to organize response, to put in place, and also even the risk communication, etc. But COVID-19 has taught us to be ready at all times. This is a lesson that we should be ready at all times. And this even made us to have, to produce a pandemic plan, which was first used in the Ebola fight. This was reviewed and updated for use to fight the COVID-19. So gaps and impacts in the supply chain during the COVID-19, we look at quantifying various impacts relative to supply and demand disruption, inadequate performance of operational risk assessment, and assessing critical data to properly assess the potential damage, and inventory recovery and evaluation processes, inability to conduct scenario planning exercise to understand operationalized implication and in line with financial and non-financial issues. So we, at the end, look at issues that we think we need to tackle, which were not adequately in place. For instance, the early prepositioning of supplies, effective coordination and collaboration, improved supply chain visibility, and model new risks and cost analysis, and also really to focus on resilience. Because all of this, what we are doing, even in the fight of coronavirus, people have to build their resilience. Countries need to build their resilience. Cities need to build their resilience. The hard infrastructure, the hospitals too need to build their resilience, and even the soft infrastructure need to build their resilience. And so government are taking a number of key actions to limit the effect of the crisis. So for now, we are reopening markets and borders to facilitate resumption of commercial trading activities. We are strengthening the social safety net, including provision of food support to households, most affected by the epidemic, resumption of construction in Liberia's major public infrastructure, private investment projects, and prioritization of government payments of goods and services providers through government ministries and agencies, implementing immediately the recovery plans for the education and health sector to safely reopen schools and restore basic health services, implement economic stimulus programs, including loan schemes, housing construction projects for low-income earners, and protecting the survivors of the COVID. And even now, we also had Ebola survivors, orphans, and health workers from stigmatization and discrimination. So now this Liberia Economic Recovery Plan, from which was produced to be effective from 2015 to 2017, was related to different strategies, medium-term interventions that will stabilize the country and spur rapid social economic recovery, while at the same time improving economic resilience to the future shocks. So the government is now working closely with the partners to implement a coherent set of medium-term programs to get the country back on the path to inclusive growth. So Liberia Economic and Stabilization and Recovery Plan was separated. We had three, let's say, strategies. One is recovery, output, and growth. The second one, strengthening resilience, reducing vulnerability. And the last one is strengthening public finances and ensuring service delivery. So now securing ongoing budget support, financial to help replace budget shortfalls. Deconcentration of public service delivery and continue to drive civil service reform priorities. So I just want to end by saying that we are looking at the two infrastructure which are termed, which has also been said, the soft infrastructure and the hard infrastructure, because we are looking at let's say well, I don't know what to get their support and their involvement, the soft, the nurses, the doctors, healthcare workers, because for this, if we look at what happened, financially, we had some gaps, and that was going to create a problem. But the government have devised means now for them to be taken care of. And even with the hard infrastructure, at the beginning, we were using, just as was said before, we were using hotels, we were using schools, etc. But a military, very big and effective military hospital was built, and is what we are, let's say, is the main
Mr. Williams, we will have an opportunity to come back to you in the Q&A session. So maybe if you can wrap up this segment.
Yeah, okay.
Thank
so,
you.
I mean, I just want to say that these were the issues that were at play. So I will stop, and I hope that during the Q&A, questions will be asked that will be answered. Thank you.
Thank you very much, Mr. Williams. That was fascinating, especially the fact that, you know, in Liberia, some of the disaster risk management structures, the national platform, etc., were used as a coordination mechanism. So all the investment that was built, that was made in building the risk management, disaster risk management system, really came in handy in coordinating the impact, the management of COVID-19 as well. Of course, drawing on the lesson of Ebola crisis as well. With that, now let me turn over to another colleague from the private sector, Mr. Hans-Peter. He works for one of the largest logistics company. Logistics, supply chains is at the center of it all in the management of COVID-19. So I give the floor to Mr. Hans-Peter to offer us to talk about how COVID-19 has affected logistics, affected supply chains, and how do we restructure what supply chains, how do we build resilience for the future. It's very easy to say that we need to build redundancies, but redundancies also come at a cost. It's not for free. So how do we make a case for it? How do we build back better from here? So Mr. Hans-Peter Toffers, the floor is yours.
Kamal, thanks a lot. Appreciate. And you answered the question already with your entry note and saying it all comes with a cost. So that's not the main point I would focus on, but I of course I cannot speak for the entire sector as the impact is very much differing on how deep you are involved and dependent on affected industry. Now, Excellencies, distinguished guests, speakers, and of course, dear listeners, let me just lead you very briefly through what happened to supply chains, and then what the impact on humanitarian efforts are, and to what extent we are able to make supply chains more resilient. I mean, UPS has been in there since many years, strengthening health systems over the globe. With commercial offers for our clients, but as well with the work I'm supporting very much as working for the UPS Foundation, the humanitarian arm of UPS. UPS has been part of Operation Warp Speed, as you might have read, so very much involved in COVID distribution. We discussed with UNICEF on the COVAX facility. We work with WFP, helping them to find out how to build effective supply chains as well for potential vaccinations. And we work with all the suppliers and as well with governments like with India, where with some investments we have been able to be part of the critical infrastructure and offer connections to support the movement of essential commodities, healthcare materials, and business products between India and the rest of the world. For instance, transporting pharmaceuticals and medical aid for the government of India to partners in countries in Latin America. Now, what happened to the supply chains in the past months? Just to pick up on a few bullet points in that regard. Supply chains in most cases are organized privately, so they follow simple demand and supply schemes, whereas in parallel, we have a lot of commercial demand that is still there. Now, what happened is that first of all, disruptions took place with the lockdown in a number of countries, and that is on both sides. So that's on the sourcing side as well as on the delivery side. I think Mami mentioned companies that could not produce anymore. That of course happened in a lot of countries as well, in established supply chains in Western Europe and in the US, because the sourcing didn't work anymore because of international sourcing processes that have been developed over the past 25, 30 years. Air cargo capacity, the fastest moving goods, was decreasing dramatically because on one hand of the demand, but of course, because of a different issue, the availability of belly loads decreased dramatically, and not only cargo planes are carrying cargo, but of course passenger flights carry a lot of cargo in their belly. And the impact was especially on low and middle income countries, because there a lot of the goods, because not that much good is transported there by air, is transported in bellies. And so the cargo capacity could not cope with the demand in a lot of cases. We have experienced that, especially in the beginning of this year with PPEs, where we had very high costs, no air capacities, and the prices per kilogram have quadrupled. It was 5 to 6, 7 times higher than before. The shift to other modes of transport did not work in each and every way. First of all, of course, there was a run on ocean. And then secondly, even rail, especially ex-China. However, the time in transit, which is a very relevant factor in some cases, is increasing as well. And there were large queues in order to reach harbors, to fill up vessels. And then at the end of the day, time in transit rose exponentially. The impact on humanitarian efforts, I would like to concentrate briefly on that one, was immense. There is a massive interdependency, sorry, between international aid and the global supply chain. So I mentioned PPE shortages earlier this year, where humanitarian supply couldn't be fulfilled. The broken infrastructure and compromised financing caused huge problems as well for humanitarian agencies. And as I said, we are very much interested in supporting better health systems globally. And that means that we must find ways to make humanitarian aid efforts affordable without hurting commercial solutions on the other side around the globe, where the traditional donors for humanitarian aid are sitting. Now, the incorporation of the private sector into discussions might have been a good starting point in some cases, especially in the light of the upcoming vaccination processes. And I'm talking about vaccination, I'm talking about testing and others. There will be a lot of supply chain activities and a lot of supply chain demand, not only for the next weeks to come, but definitely for months leading into 2022 for sure. And here, and that's the complexity of it, we are not only talking about availability of cargo, availability of airplanes or whatsoever. So there were some numbers that were, shifted around in the news in the past weeks, like 8,000 planes are necessary in order to transport all the vaccinations to all places in the world. Well, fact of the matter is that usually those vaccines will not be transported all at once, especially because the production of vaccines will take a while. So we heard about the doses that are available. And so I can tell you that the doses that are available in those countries where we are organizing supply chains, we are able to deliver them. So that's not the issue. The issue on the other side is that we have to talk about the organization of deliveries. There are multiple vendors with different preconditions. We have the temperature needs, temperature control. Is it 2 to 8? Is it frozen? Is it minus 80 degrees Celsius? Different vaccination processes as well, shipment readiness, the time between the production and then the shift into transportation supply chains needs to be managed well. So there is an information management system necessary that helps as well to deliver the figures, so that the actual data that can be used then through the entire supply chain. There is a need for cargo control as well. On the other side, it does not make any sense at all to deliver vaccination to a place somewhere in an LMIC where the refrigeration processes are not in the best shape, so that at the end of the day, you have a damage of thousands of US dollars and no vaccines at the point of delivery. So there needs to be a controlled process in that regard. And then there are challenging routes, of course. We have seen that in our support measures from the foundation, especially when you're going into places like Central African Republic or so. So you are definitely not able to deliver, to find any alternative, maybe to the one provider who is willing to fly into a given place. We have done that 2 months ago already. So I know what I'm talking about. So solutions, just getting into that. How to make supply chains more resilient. I mean, it's not an easy process for sure. So no easy answers. We have supply and demand schemes. So the main demand is commercial for sure. And they are for sure, you just need to talk to producers. You will find out that they already started to discuss their own business continuity plans and how they have to build that into DRR. I mean, there was a concept of local sourcing that has been discussed in a number of different states, which then would rely on a completely different type of supply chain, which is more local or regional. Is that the solution? Well, maybe, it depends a little bit. But on the other side, we have very much established economic work sharing process, international work sharing process, and it has a value on its own, because international work sharing as well leads to well-being in countries where this economic development is taking place. So we have economic development in countries where production could be sourced out to, and I don't think that we want to destroy that. And it's not only about the costs, it's as well economic development in third world countries. Now, the business continuity plans and the focus on integrating and incorporating supply chains better into DRR is definitely one aspect. The other aspect, and it has been mentioned already, is special procurement plans that can secure supply chains as well, because at an early stage, providers of supply chains are knowing what the demands will look like and can build reserves. We have seen that in a number of countries, and we have been involved into that as well. So what in any event is relevant from my perspective in order to safeguard that the situation as we had it earlier this year is not repeating, is to run simulations in order to make sure that we have a good perspective on what can happen in case of a given situation. I mean, the current situation is definitely the worst thing we have seen for decades, no doubt. I mean, we have been in the discussion on Ebola as well, but Ebola was a box problem. It was more or less happening in a number of countries in West Africa, mainly. The same thing was some of the SARS deviations of viruses that we had in the past years, very much located. So it was not spreading over the entire world, and we were able to, with relatively manageable efforts to keep that under control. This thing here, COVID, is definitely something else. This is a completely different animal, and so therefore, if we want to prepare for that, in order to, coming back to your entry point, Kamal, without causing costs that nobody is able to afford, nobody will be. We have to make sure that through simulations, we have an understanding, what do we want? And then make decisions, which might be political, how we can cover that. With the cost of infrastructure, it is infrastructure, that's what we are talking about. And then find out what we want to do and what we are able to afford. I pause here because we are running out of time, I think. Thanks for listening.
Thank you very much, Hans-Peter. That was a very insightful presentation. I latched on to every single word you said in terms of what really happened in the current pandemic, to the supply chains, the complexity of delivering vaccines. It's not just about planes, although I'm very hopeful when I look at your backdrop, it looks like a UPS plane on its way with the vaccines. But so there are many complex dimensions to it. You highlighted in the end that, they actually simulating different scenarios and look at what is the level of resilience we should be planning for, what would it cost, where is that sweet spot between resilience and efficiency. That is something we have to really, there are no easy answers, but we have to grapple with this. We are running out of time. So the final speaker on the panel, Professor Rajiv Shaw, he chairs the Scientific and Technical Advisory Group of the UNDRR. He has been also at the forefront of capturing the lessons that we are learning from COVID-19 in different parts of the world and what it means for building resilience for the humanity in the future. So I give the floor to him now to talk about it as to what is it that we have learned from a science perspective. What would the science of resilience, what should the science of resilience look like in the post-pandemic world? Rajiv Shaw, the floor is yours.
Thank you. Thank you very much, Kamal. I understand that we are a little bit running short of time, so let me be very brief. Excellencies, ladies and gentlemen, thank you very much for giving me this floor. Let me give you some specific examples with some historic development. Recently, I was reading an old report of WHO, which was of 1997 actually, and the report is titled Earthquake and People's Health. And this particular report was triggered by the Hansinawaji earthquake, which is the Kobe earthquake of 1995. During the Kobe earthquake, there were many damages to the hospitals and the health centers, and there were loss of people's data. So there are two very specific recommendations which came out of that particular report, was the need of structural safety and the backup of the patient's data. So that was in 1997. 10 years later, in 2008, 2009, some of you may recall that time UN ICDRI, they launched the hospital safety campaign. It was along with the Safe School and Safe Hospital, 1 million safe school and 1 million safe hospital. So it was more focusing on the structural, but certain aspects of the non-structural safety. That was in 2008, 2009. In 2011, when we had the East Japan earthquake and tsunami, what you call the Tohoku tsunami, we found that the hospitals were structurally safe, but the non-structural and the functional damages was huge. In the worst case scenario, we did not take into account the human resource losses, especially the frontline health workers and their families' life loss, accessibility to the hospital, and the long-term power disruptions. In 2018, 2 years back, in Japan, we had a major flooding in West Japan, and we found that a couple of major hospitals being located in the floodplain, it got inundated up to the second floor. So most of the important and expensive equipment, like the CT scanner and all these things which were located in the first floor, they got damaged and could not serve the people for some time. And in 2020, like this year, we have been seeing for last several months, you have already pointed out many different issues. But one thing I would also like to point out is not only just the COVID, but the cascading disasters like the typhoons, flooding, heat waves, which are happening during this prolonged period of last 1 year, and how it is actually affecting the critical patient, how it is affecting the whole healthcare system. So with all this historical perspective of last 25 plus years, I would like to point out 3 very specific gap areas, which possibly we still are trying to struggle and possibly we need to think about in future. Number 1 is to look at more comprehensive resilience perspective of the healthcare system. So far, we have been focusing on the structural issue, non-structural issue, functional issue, locational issue, human resource issue, data backup issue. So there are many different types of compartmentalized aspects of the healthcare system. So one of the first and major challenge, and that is a major takeout message for me also from this particular COVID-19 experience, that to look at more on the holistic aspect of the risk assessment and try to look at the worst case scenario. And possibly in the worst case scenario, we often forget to link with different types of cascading disasters. We often have our worst case scenario, only one type of hazard. So how we have a multi-hazard cascading worst case scenario. So that's number 1. Number 2 is, I think we need a thin line between this term called cure and care. Although we talk about the healthcare system, but it's still very much the cure part. Like when you have already got some disease, but how we can have some more preventive care system. I think that's a very, very important system, and how we can make that whole healthcare system is a more care-oriented, not just cure-oriented. And there, I think the more the informal healthcare facilities, more the community-based healthcare facilities, more possibly having some sort of community-based social safety net, I think those are very, very important. And the balance between this cure and care is very, very important. And that's my second point. And my third and last point is the inclusiveness in the healthcare system. Still, I think in developing country, in developed country also, we are seeing still there are this balance, the imbalance between the have and have-nots about the healthcare facility. So how we can make the healthcare facility more accessible to all different age groups, to all, whether it is in the rural area, urban area, all different generation and so on. So these 3 very specific issues, one is comprehensive healthcare system with worst case multi-hazard scenario planning, number 1. Number 2 is balanced approach of cure and care with the social safety net. And number 3 is this inclusive healthcare delivery mechanism. I think these are possibly the 3 main key learning, which I found not only important for this COVID, but also possibly very much important in the post-COVID scenario. Thank you very much, Kamal. I will stop here.
Thank you, Rajiv. Those were excellent remarks. And I think this whole thing of, cutting across multiple aspects and assessing risk across different components of the health infrastructure system is key. The balance between cure and care, and of course, the whole issue of equal access. WHO colleague in the beginning also highlighted that. So I think it's been a very rich discussion. We are already 5 minutes over time. So if I may suggest two things. One is we have a second question that we will take. And then there are some burning questions, but I will reduce all of them down to just one question, which I will direct to our private sector panelists, the two of them, Dr. Reza and Hans-Peter. I'll come to that in a minute, but let's hear the poll question first. So how should healthcare infrastructure be strengthened to prevent another pandemic? Ensure adequate medical supplies, establish and enforce testing and contact tracing protocols, build well-equipped health facilities and repurpose large facilities, create empowered national task forces and institutions for immediate pandemic response. Of course, we need to do all of this, but the point here is to pick one which is the topmost right now. Of course, with the recognition that it's not a choice between these four, but more of a prioritization where we found ourselves most lacking this time, so that we need to prioritize that. The poll is on. Very interesting. So it's really a risk governance dimension which is coming out very strong, where colleagues are saying that create empowered national task forces and institutions for immediate pandemic response. So, national task forces, implicit in it is the notion that this has to be multi-sectorial, and institutions that have the capacity, that have the resources and the orientation to respond. That is the key thing. That is the top priority. Again, emphasizing that all the other three are also have to be done, but this is where we could have perhaps done much better than we did in COVID-19 if this was strengthened. So thank you very much. I think this has been a very, very interesting poll, and thank you for participating in the poll. Now, my question, in the first poll question, everyone talked about having excess surge capacity and stronger supply chains as the thing. And Dr. Raza Siddiqui gave a very interesting example from UAE, how public and private sector came together for management of COVID-19. Hans-Peter painted a very comprehensive, nuanced picture of what happened to the supply chains, what do we need to do in the future. Now, my question to both of you is that if you had to meet, had the opportunity to meet the highest level government functionary in your country for 1 minute, and you could ask for anything in terms of a policy enabling environment for private sector to play an effective role in managing a health emergency of the kind we are witnessing right now, what would you ask? May I ask Hans-Peter to go first, and then Dr. Raza Siddiqui, or your choice?
Well, I'm on right now, so let me quickly answer that. What I would be very much interested in getting a good forecast on the expectations, so that that you can describe a cooperation model well, and make sure that you are able to bring the resources to the table that are necessary. So for cooperation, we need unified information, and unified information means as well information that is actual, that is coming from one source, that is not distracting, but which is pretty much forward and offer you a very frank view on the situation, so that you can make sure as a private sector participant in a collaborative project that you, as said, bring the right resources to the table. So that is what I think would be my #1 question.
So I think that's a very, very interesting point. So the work for the public sector and the governments is really cut out to provide timely information as best as possible as is feasible, forecast of what is the requirement, so that private sector comes to the table in an informed way and can anticipate. Thank you very much. And I think that's clearly in the public policy domain, the whole issue of information management for requirements. Dr. Reza Siddiqui, you have the final word.
Thank you very much. Hans has addressed it very well. It is very important that we are in a collaborative model. We are not in competitive model. And in healthcare industry, governments all over the world have realized that they cannot alone do it. It has to be in partnership with private sector. So I think I will again give example of UAE. For example, in UAE, every 2 years, you have a strategic plan from the government where they identify areas where private sector has scope to invest. So it is very, very empowered decision-making process for the private sector. So if I get a minute with the authorities, I think this is what we will talk about, that identify areas where private sector can effectively contribute, collaborate in providing international quality healthcare, both in curative and preventive manner.
Thank you very much, Dr. Reza. That was a quotable quote. We have to be in a collaborative, not a competitive mindset when it comes to public-private sector. And also, if the government can set up some sort of a blueprint as to which are the priority areas where we need to work together, that would be very helpful. So thank you very much. We've had a very rich, about 100 minutes or so, discussing the Build Back Better in the context of supply chains, health infrastructure systems, and so on. I will not try to summarize everything, but we've had a very rich discussion. We've heard the public sector perspective from departments of disaster risk management, from departments of health. We've heard the private sector perspective. We've heard the science perspective as well. All of that can really be brought together in terms of formulating an action agenda for a Build Back Better recovery. It's been an honor spending the last 100 minutes with you. We have got a lot out of it. This webinar is a milestone, not just towards ICDRI 2021, but both UNDRR and CDRI will be working together in this space. So this is not just webinar. We will also be pursuing some concrete action with in support of our partner countries, with our delivery and knowledge partners. So this has been wonderful. May I request everyone to be here so that we can just take a quick photograph. The organizers are requesting that we do a panel photo. And that, as moderator, I sign off. I would like to thank everyone, the team in the CDRI Secretariat, colleagues in the UNDRR, Abhilash Panda, his communication team, in putting this together. As I said, this is just one step. We will be following up, and we look forward to working with you closely in the months and years to come. Thank you very much. Now on to the group photo. So over to the organizers.
Thank you very much, everybody. Have a good day ahead.
Thank you.
Thank you. We sign off from here. Bye-bye.
Thank you, Kamal. Thank you, everybody. Bye-bye.
Thank you, Kamal, for your moderation. Bye.
Thank you.
Bye.